Welcome to Health Matters, where we explore key topics from a primary care perspective. I'm your host, Dr. Sheylan Spencer. Here at Vandalia Health, we are passionate about bridging the gap between primary care and specialty medicine, ensuring that complex medical topics are accessible and understandable for healthcare providers and patients alike. In each episode, we'll dive deep into the latest advancements, best practices, and critical insights to help improve patient care. Thank you for joining me on this journey toward better health. Today on Health Matters, we're joined by Dr. Jeetu, Nanda, a seasoned physician executive and respected leader in healthcare innovation. Dr. Nanda has held key leadership roles across some of the nation's most prominent health systems, from his 21 years as vice president at SSM Health to serving as CMIO at Springfield Clinic, to leading as a senior physician executive at Oracle Cerner, one of the world's largest healthcare technology companies. He's also brought his expertise to Cone Health as Senior Vice President and CMIO. He is now serving as the CMO of Vandalia Health Network. Dr. Nanda's experience spans every level of healthcare delivery, whether it be from hospitals to integrated systems, with a focus on population health, medical informatics, quality, patient safety, and innovation. Known for his skill in health finance, process improvement, and leveraging technology to improve care, he continues to stay connected to patients as a practicing hospitalist. We're thrilled to have him on Health Matters today to just more or less talk about how health systems can innovate, integrate, and deliver better care for the communities they serve. Dr. Nanda, thank you so much for just being here with us today, and interested just to be able to get down and sit and talk with you today.
Thank you for inviting me. Happy to be here and happy to be at Vandalia Health.
So just going through your resume, you've lived and worked in, a number of different places throughout your career. Do you have a favorite city or region that's really felt like home for you?
Home is, I think, where I've spent the most time, and that's been St. Louis. Growing up around the world with my dad being with the UN, every place has its own charm, and home is, the kids were born there, and I lived in St. Louis for, 21 years. So I guess that's home.
Do you guys get a visit frequently, or?
We do. Lots of friends out there, and recently we were there for a wedding, and I still do some hospitalist work at my old stomping grounds, so it works out.
So just trying to get to know the man behind the title. When you're not, leading large health systems like Vandalia Health now or seeing patients, what do you like to do to unwind?
I listen to Indian classical music,
Absolutely.
Deep classical music that even the family is like, oh my God, he's, get out of here.
Dad's putting that on again.
So a glass of scotch and classical music
a true gentleman.
Helps me unwind.
Absolutely. That's good. So we just like to get to know our guests. How do you start your morning? Are you a coffee person? Are you a tea, or just something else entirely different?
Black coffee.
Black coffee.
Yep. So
your Starbucks order is super easy then. If I'm making a Starbucks run, I know that Dr. Nanda just wants a large black coffee.
I just brew it at home. I don't even go to Starbucks.
Not even the Starbucks. So,
no.
Well, I appreciate you humoring me. With every guest that we come in here, we just like to get to know the person behind the title. And so, Dr. Nanda, just to start off, can you just give our listeners kind of a big picture definition? We talk about population health, and I know as a previous resident, that's not something that I was too familiar with. Can you just kind of expand on that for us?
Sure. So population health, when you say population, that can mean anything, right? It could be a geography. It could be a cohort of people in a specific financial group or a specific occupation, whatever it is, right? A cohort of people's population, mm-hmm. right? And health kind of encompasses all aspects that allow a person to live the best life that they can, including genetics, environment, housing, transportation, finance, community health, all of that is part of providing health. So we kind of define that as social determinants of health now.
SDOH, yeah.
But these have been there for years. That we may not have paid attention to, but they contribute more to a health of a person than actual diseases. So now we're trying to get all of that captured to make sure that we're taking care of the whole person and keeping them healthy.
That's a beautiful definition. When we're talking about population health just in general, how would you say that differs from, I don't know, like your traditional patient care model, where we're just focusing on the individual?
So the current patient care model is acute care, whether it's acute care of an acute illness or acute care of a chronic illness. We focus on sick care. Population health would focus on keeping the patient healthy.
Absolutely.
I, of course, joke around saying if a patient comes to me that's healthy, totally useless to me. I do a full physical, make $150 or what, a year. That's it. The way our healthcare system is set up, if the patient is sick, COPD, diabetes, they're coming to me every 3 weeks, every 4 weeks. I'm making $250 a month off of them. So changing the paradigm to keeping the patient healthy is what population health aims to deliver. Right person, right time, right cost, allowing the right outcomes to promote health.
Beautiful. You're really able to break that down. Just going back to your role as like a CMO, what are some of the metrics or what are outcomes that you were kind of looking at when you're, I don't know, evaluating population health initiatives as like a whole?
Yep. So with population health initiatives, I focus on the quintuple aim, and you'll hear that. It's clinical outcomes, patient experience. Patient experience is important because if a patient does not have good experience with your health system or your office or any interaction you have, the chances of them coming back and having that stickiness with your organization or your office or yourself as a provider declines. And
Absolutely.
So patient experience is very important. Provider satisfaction, another huge thing. We used to think of the customer is the most important person, right? Customer first. But there's another way of looking at it. Employees or providers first.
Absolutely.
Because a disgruntled, unhappy employee or provider is not going to be able to provide good care to the patients. So we need to make sure that our providers are happy, whether making their life easier, helping them do the right thing easily, and also making sure that they are practicing to the top of their license and not doing things that are administrative burdens, and that takes away from patient care and provider satisfaction. I mean, I think all providers that trained with the idea to help our patients and help the population that they live with, the communities that they live with. Financial sustainability, right? Very important. You've heard no margin, no mission.
Yeah, absolutely.
So absolutely necessary for us, whatever we do, we are able to sustain our organizations or our programs financially. And health equity. Health equity is important, especially in states like West Virginia, where just because you were born here and live in a rural community should not mean that you don't have access to quality health care, right? And we strive to deliver that, but we have to pay attention to that so that we are always aware of those constraints that exist in communities.
As a resident, and even as an attending, you often hear people talking about clinically integrated networks or CINs. I'm sure there's some of our listeners who are not necessarily familiar with what a clinically integrated network is and why they are becoming just such a critical piece of modern healthcare delivery. Can you kind of expand on that?
Sure. So care delivery today is very fragmented, right? You go to primary care for something, you go to a specialist for something, you go to different labs for different diagnostics. The left hand usually doesn't know what the right hand is doing. So the concept of clinically integrated network is to coordinate all of that. So the concept of continuum of care, womb to grave.
Yeah.
Right. The health needs significant coordination for a couple of things: for outcomes to be better, and for cost containment. Right. I mean, you are not doing the same tests a few times because you didn't know that test was recently done. Right. So that kind of coordination is what clinically integrated networks do. Now, when you do this coordination, you have to have alliances with various delivery systems and even, say, specialists.
Absolutely.
So hospitals, specialists, primary care, rehab, skilled nursing units, etc. Now, you can see where if you did that without a clinically integrated network, it would be construed as a monopolistic path.
Absolutely.
Right? Which the regulators would come and shut it down. So forming a clinically integrated network which concentrates on delivering quality outcomes as the main focus, and then connecting all these segments of healthcare that deliver care is a safe haven.
Absolutely.
And so you can do that without any fear of being cited for monopolistic.
So I'm hearing improving patient care and cutting down on the cost of healthcare itself.
Correct.
Completely makes sense. So how does Vandalia Health clinically integrated network work in practice? Are we having are independent physicians and hospitalists and specialists collaborating within a structure?
Yes. So you have, in clinically integrated networks, you have either a integrated delivery network sponsoring it, like a health system. You could have a group of physicians getting together and forming a clinically integrated network. Vandalia Health Network is sponsored by an IDN, Integrated Delivery Network, right? So all the employed physicians are part of it. Then we collaborate with other independent offices, FQHCs, rural health clinics, as well as having joint ventures with rehab facilities, SNFs, home health agencies, hospice agencies. So that's kind of how our clinic or clinically integrated network works. And the idea there is, because we're taking financial risk for this, you want to spread that risk to as many patients as possible. And for that reason, you bring in the independent providers so that their patients also become part of the cohort that we're taking care of, and therefore the risk is spread. Because you can imagine if you have, say, 5,000 patients and 200 of them go on dialysis, right? A dialysis patient costs about 9 to 10 times that of a regular patient that doesn't have dialysis. So if you have enough of those, you blow your budget. Yeah. Unless you spread it out among more folks. So that's kind of how our clinically integrated network works.
What are some of the challenges that you're seeing, really just with maintaining alignment and engagement across so many different providers?
Wow, many challenges. So
Loaded question.
So one is technology challenges, right? For us to be able to do that, we need to be able to get digitized data from, we have 14 different EMRs into one data warehouse where that data can be normalized for analysis to happen. So the analytics to happen so that we can then segment our population to deliver resources as needed by those segments, right? So that's a huge challenge. Attribution is another one, right? So we have our payers attributing with a different algorithm as the EMRs are set up with a different algorithm.
Yeah.
CMS has a different algorithm. So all of those things have to be brought into a single accepted algorithm across the system. Reimbursement challenges, right? That's a huge thing as well, because most of population health management requires upfront investments that you're going to recover later, but upfront is required. And if you don't have those, which you make available because of reimbursement that you're getting from the payers, it's almost circular. But reimbursement challenges, change management, it's different, right? We have been so used to sick care. So thinking about how we keep patients or our folks healthy is a paradigm change, and that change management is difficult. And we have to do that change management with 1 foot and 2 canoes, because you need to make sure that the fee-for-service, as we transition, is also well managed, as well as the population health part of it, the value-based care part of it. Challenges with primary care versus specialists. How do we manage primary care? What are their responsibilities? What are specialists' responsibilities? We got to get all of that, and thought alignment in all of this. We got to make sure that everyone is rowing in the same direction for the boat or the canoe to move forward. And if you have people that are not totally aligned, that creates a challenge.
Quite a number of different challenges, like whether it be in technology or just the paradigm shift, like you had mentioned. But we talked earlier about some of the benefits too. We talked about improved quality of patient care, and then we also talked about eventually lowering the cost that the patients. What are some of the other benefits that you're seeing with CINs, or can you just expand on that a little bit?
So care coordination is important, right? Chronic care management, right? So while you're working on keeping patients healthy, communities healthy, you already have disease burdens with patients that have illnesses, right? So you got to take care of that as well. So clinical outcomes, just think of, say, and when you talk about costs, think of colon cancer, right? It's better outcomes if you do the colon cancer screening ahead of time and find something early and take care of it, versus allowing a patient to have, not allowing, but finding a patient who already has colon cancer. Okay, so that becomes costly, as well as the outcomes are not as good, right? So the quality measures that are put into place are more preventive: mammograms, colonoscopies, immunizations, ahead of time to make sure that the patients remain healthy. So those things in the long run cost much less, and the outcomes are better.
Makes complete sense. Sounds like the job for primary care, and for some of my colleagues back in family medicine, we would love that paradigm shift. So now just kind of shifting gears a little bit, You often hear, whether it be in residency or on as an attending, we hear about accountability care organizations. How are ACOs fitting into this picture?
Yeah. So accountable care organizations were or are CMS, Center for Medicare and Medicaid Services. Their plan to slowly move the risk of patient care and outcomes to providers. And to do that, they formed a group of traditional Medicare patients in a community, at least 5,000, can form an accountable care organization. And how that works is, again, you spread the risk over 5,000 patients at least, and we have like 15,000 or so ACO patients. And what comes with that is, so far, it has been upside risk only. So if you meet all the quality measures and you save Medicare a certain amount of money, you get rewarded for that.
Absolutely.
Where it's a split of whatever you saved. Now, come 2027, we're going to have a downside risk, and it's going to be a gradual increase in that percentage risk as the years go by. And at some point, more and more risk will be taken by providers than the payers. Because right now, payers are the ones that are taking all the risk. So that's the idea, and the best outcomes have been shown by organizations that have taken risk. And the reason that quality is important here is if you're taking financial risk, you might as well not do anything quality and save the money, right? Year after year, you'd be making money. So that's why there are quality metrics that you have to do those quality metrics and then make care more efficient so that you're saving money. So CIN is overall integrated network, and part of that with Medicare, traditional Medicare patients are ACOs.
What roles are you seeing that ACOs are playing in really just advancing the goal of population health and CINs?
So ACOs, depending what Medicare has done, is depending on where you are, there's a per member per year average spend that Medicare has a budget to spend in that area. So it does a couple of things. One, it can make a contract with an ACO, accountable care organization, or it does with other payers, and those things are called your Medicare Advantage plans, managed Medicare by another payer. So ACOs are basically the organization, the accountable care organization, whatever the name, it's CAMC, ACO, then manages that patient population as well as the monies allocated with the outcomes.
You kind of touched on this already, but just expanding. You hear the term value-based care thrown out a lot, but certainly that can mean different things to different people. How would Dr. Nanda define value-based care, more so in the setting of Vandalia Health?
So value-based care, as I've said before, is us taking more risk, right? So as we prepare, we've never done this before as a nation, right? We've never done pay for performance. Okay, so that's basically the most basic part of a value-based care. You meet certain performance metrics and you get paid a certain amount. Now, if you step back a little bit, most of your integrated delivery networks have employed populations, right? Their employees. And the insurance that they provide for their employees is self-funded by the IDN. So in essence, they're taking full risk on all their employed population, right? So when you look at your insurance card and it says Highmark or says Cigna or whatever it is, that's a third-party adjudicator for a plan that our own company has developed.
Yeah.
So we're taking full risk on our, and we should learn from that, right? So what are the costs in this area for certain things? Population is a little different though, right? So your employees are mostly better off financially than some of the other folks, younger, right? So and perhaps less disease burden because they're able to work.
Absolutely, that's
Right.
what I was thinking.
So when you become disabled, quote unquote, then you go on Social Security and Medicare, and depending on your financial status, Medicaid, right? So we take full risk. The next level of pay for performance, the next level is upside risk only. So there's a bunch of money, you got this, these metrics. If you meet those metrics, whatever you save, you split. And then there's two-side risk, and that's if you lose money, then you get to lose. You have some clawback by Medicare. So it's a whole stepwise process for you to prepare to start taking risk. Now, some of these companies, healthcare companies, have become payviders, payers as well as providers. So one arm of them is the insurance company taking risk, and the other arm is the delivery of care. So Kaiser Permanente is an example. Geisinger in Pennsylvania. These are companies that have a payer side of it and a provider side of it. And when you have those, the paradigm shifts because now you're looking at both sides. Now you're willing to spend resources up front to make money in the back end. And that's the payer side of it. So you have people doing things like food pharmacy, right? So if you're a diabetic, you can go to your doctor, they can write you a prescription for diabetic food, and your insurance company is going to pay for it.
Oh, wow. Yeah. Would
Right?
love to have access to that.
So those things will happen once a significant amount of the revenues for a health system are in the insurance arm or the payer arm. So just different models. And there's no one model that works. Most people have few different models and see which one they want to concentrate on and which one is most effective and most appropriate for their communities.
Absolutely. Walk us through, what does it look like day to day whenever our providers are incentivized around outcomes rather than just volume itself?
That's actually something that we're still learning. How do you incentivize providers? Part of their salaries being tied to quality measures. Part of it tied to cost measures, maybe. We can also segment the providers and preferentially bring providers into more lucrative contracts where they have the possibility of more income because they are high outcome, low cost providers. So there are a lot of challenges there. Specialist wise, there's thought of, do you just pay specialists not to do things.
I can see. Yeah, I see what
Right?
you're saying. Yeah.
Right? I mean, how do we incentivize our specialists to do procedures that are absolutely necessary in this setting that's absolutely necessary? Give you an example, right? If a patient is coming in with, is vomiting blood, and you've got 8 hours while we're waiting for a specialist to come in, 8 hours of stable blood counts. Very unlikely that that's a lower GI bleed, right? If the patient's stable and stable blood counts. Absolutely appropriate to do an upper endoscopy. But a lower endoscopy in the hospital setting may not be appropriate.
Yeah. Yeah.
Right? Should they have a colonoscopy? Absolutely. But perhaps in the outpatient setting where the cost actually may be more beneficial for the clinical integrated network or an ACO versus doing it in the hospital.
I see what you're saying.
But again, there are caveats. There are exceptions to that. I mean, what if that is the only time that you have a captive audience or you have the patient there, and once you discharge the patient, they never follow up? Yes, there are some instances of that. We need to consider that. But mostly, just right care, right time, right place for the right outcome.
Thanks for walking me through that. That was beautiful. Just kind of shifting gears a little bit. How are you envisioning data and technology to help manage our population in this value-based agreement?
So as I had said earlier, data becomes actually one of our most valuable assets, right? That data can be analyzed for us to focus on certain cohorts, focus on certain areas, direct our resources to those areas that need it the most, right? I mean, in any industry, you've got resource constraints. And how you succeed there is how do you most efficiently use the resources you have. Technology helps by automating certain things that can be automated so that our human resources or people are freed up for doing things that technology can't do. And one of the things with technology is, again, as I said earlier, we need upfront investment, right? You got Powerball, what is it, 480 million or something like that, right? But you can never win that unless you buy the ticket.
Yeah, sure.
Right? So you have to have an initial investment and again, not haphazardly investing in all kinds of technology, but very focused technology that helps us do something that takes a lot of time or takes a lot of human time to do, right? With AI now, there's a lot of stuff that can be streamlined. We are using AI now to capture more revenue. But people are not lining up to pay us more.
Yeah.
Right? Even if you find things that you want to bill for, they're not lining up to pay us more. So when you're talking about margins, you're talking about revenue minus expense. So to increase the margin, you can increase revenue or reduce cost. And you can actually use technology to reduce cost and improve efficiency, right? Data. So give you an example. The OR is one of the most expensive areas in any hospital, right? How do you make the most efficient use of it? Today, we have block times, whether those block times are used or not. So when the OR is not used, that's a resource that's an opportunity cost that is lost because that resource is not being used, right? So we can actually use AI agents to look at the patterns of how those expensive resources are used and suggest how we can streamline that so that it's always in use, right? That's what's generating a lot of revenue. So technology, case management, for example, right? So we have so many case managers that will do case management. Well, can we automate some of that? Some of the stuff that absolutely doesn't need to be a person. Can we automate a phone call, ask questions, just like your generative AI does, and record the answers?
Yeah.
Right. So that, and if there's a snag, if there's something that algorithm is not able to process, you have human intervention, right? So that simplifies and reduces the work burden on a lot of folks that are really trying to do their best. There's just not enough time in a day to take care of the number of patients that they care for. So,
I think earlier you'd mentioned that Vandalia Health will be participating in a risk-based Medicare program in 2027. Explain what that transition involves.
This is not administration dependent, meaning which party is in power. It has continued where 2030, all Medicare patients and all Medicare patients and most Medicaid patients will be in a value-based agreement, whether voluntary or mandatory. And whether this is an accountable care organization, a bundled payment arrangement, or a capitated arrangement, whatever it is, all of them will be in a value-based care, which means that they will be risk sharing with the providers.
Yeah.
Now, for us to get to that, we're slowly taking smaller risks. So in 2027, all our ACO patients, we will have a 2% clawback. So if we don't meet certain metrics,
I see what you're saying.
cost metrics and quality metrics, Medicare can take back 2%. And if you look at the numbers, 15,000 patients, just rounding up, making up some numbers, 12,000 per member per year. That's a lot of money. And 2% of clawback, when health systems today make about a 2% margin on the revenue of whatever it is, $3 billion, $4 billion, $8 billion, still the margins are about 2.5% if they are in the black. So 2% clawback is a lot of money.
Yes, it is. Yeah.
And so we need to prepare Vandalia Health network and system to be able to take that 2% risk by 2027, which increases to 4% by 2028, and 8% to 2029. So this is incremental risk, and to be able to do that, we need our processes in place, our technology in place, and alignment in place, right? So by processes, I mean, do we do tests that really don't contribute to the care of the patient?
Yeah.
Whether it is diagnostic or even therapeutic. Those need to be streamlined, whether evidence-based or as a system consensus-based. Right, our GI folks like it this way, as long as there's consensus and there's no because every variation costs money.
Yeah.
And so if you streamline that, then you have a consistent way of taking care of patients. And from the quality point of view, what it says is regardless of where the patient comes in contact with our health system, they will get the same quality of care. Right? So from a quality of care point of view. So we've already talked about technology. Alignment is the other thing. Can we keep those patients within our network where cost and quality are known to us, versus if they are referred out to other health systems, we've got no clue about their costs of care of a similar disease process. So then those are surprises to us, where your financial folks will tell you that if they know, they can budget to it. It's the unknown that hits with, as a surprise, and it's more difficult to cover that than to cover things that are budgeted.
Absolutely. So we talked about this transition. What are the operational or the clinical changes that's going to have to take place and really to get that alignment that you'd mentioned?
Yeah. So operational changes, robust data warehouse.
Yeah.
Right. So you've got real-time data, quality data, cost data, and technology that connects folks. Just give you an example. Today, if a patient goes to the emergency room, right, even before the patient goes to the emergency room, do we have any process for that patient to get in touch with someone that can direct them? Hey, does this need to go to an urgent care emergency room, or can you wait for your primary care tomorrow morning? We need to put that in place. Once the patient goes to the emergency room, there should be a mechanism that the primary care is notified in real time. Hey, your patient is here with this, and that should prompt a phone call from the primary care to the ED doc saying, hey, I just got this notification, my patient is there, what's going on? How sick is the patient? Or because the primary care knows the patient better, can you do this? Does the patient absolutely need to be admitted? If the patient is really sick, needs to be admitted, no problems. The ED doc admits the patient. But if it's
I see what you're saying. Yeah.
At a point where, maybe admit, but may not, and the primary care says, send the patient home after these tests. If these things are normal, I'll see the patient tomorrow morning. The ED doc has no problems documenting that and saying, spoke to the primary care, we'll see the patient tomorrow morning, and discharge the patient. You just cut cost of an admission.
Absolutely.
That would have happened today if we don't have those processes in place, right? Once the patient goes, do we have mechanisms that the patient will be seen the next day, right? And be taken care of? Do we have resources where we can send an NP and a nurse to a patient's home because they're short of breath? What processes do we have in a skilled nursing facility? Today, if the nurse taking care of the patient who was just discharged from the hospital is short of breath, say was discharged with congestive heart failure that is in remission, and the patient becomes short of breath, knee-jerk response of the nurse is send the patient back to the ED, the emergency room. But if the nurse had a provider that they could talk to and say, hey, this patient is short of breath, and the provider has information about that patient available to them electronically, can look at it and say, well, the patient has COPD, let's go ahead and do a neb treatment.
Yeah.
Or the patient has congestive heart failure, let's go ahead and give some Lasix, wait for 2 hours, see what happens, and then send the patient if the patient is not improved. So again, that's palliative care. Huge thing, right? We don't have enough palliative resources here. And, if palliative care got involved, 50% of our Medicare dollars are spent in the last year of the life of life, and if we had palliative care consults and our patients were better informed, we would not waste that much money in those last years or last months. And patients would have better quality of life at home.
Absolutely.
With their families and spend the time that they have instead of spending 80% of that time in the hospital.
It's a benefit on both fronts.
On both fronts.
And with the new palliative care fellowship, that's just another tool that hospitals will have to be able to connect these families to palliative care to hopefully get established and be able to see them on an outpatient basis. So just kind of jumping forward, we talked about risk-based models. We've briefly touched on risk. What type of risk are we referring to specifically? Are we talking about financial, or is this clinical, or is this more or less both?
Well, it's the risk is financial.
Yeah.
Right? The risk is always financial, but quality metrics play into it because, one, it does cost money to do those quality metrics, but in the long run, those quality processes or procedures that we do help prevent costly diseases later on, and therefore that financial risk is mitigated. If you don't do those quality measures, then the risk is that the patient will get sick and you will spend more money in the back end.
Self-explanatory. You briefly touched base earlier too, just kind of mentioning that in 2030, all Medicare patients will need to be in some form of value-based arrangement. We talked about kind of preparing for that. What should providers and patients be doing now? Is there anything that they could do now?
So, providers, of course, pay attention to quality metrics and get them younger, right? If you're doing preventive stuff and the patient's 80 years old,
what are you preventing at that point?
Right? What are you preventing at that time? So this thing needs to start way early, and that helps with a lot of things as well. Our metrics are not very good. So going back nationally, why are we doing any of this? Because the current model is not sustainable. Mm-hmm. Just give you an example. We spend in the U.S., and we'll just compare U.S. and Canada, right? We spend $14,800 per person per year in the U.S., 17.3% of our GDP. In fact, the entire GDP of Germany is spent on healthcare every year in our country. If you go across the border, they're spending $6,200 or so.
Half.
Less than half per member, per person per year. Okay. Oh, well, then they must not be getting good care. Infant mortality per 1,000 births in the U.S. is 6. Canada, 4. Maternal mortality in the U.S. is 21 per 100,000. Canada is 11 per 100,000.
Quite a difference.
Okay. Life expectancy. Actually, crossing the border gives you additional 3 years.
Oh, wow.
On average. Okay, so 79 is life expectancy here. Across the border is 82.
Oh, wow.
Right? Then we say that acute care, if you were really, really sick here, our systems are in place to take the best care. Chances of a heart attack death in the U.S. 71 per 100,000. Canada, 45 per 100,000. So even acute care, cardiac care that we are supposed to be really, really good at.
Yeah, sure.
There's still a 1 3/4 chance of you dying of a heart attack this side of the border than that side.
Puts that into perspective.
Right?
Yeah.
So we can't continue to spend 17.3% of our GDP, 14,000 year after year after year. It's just not sustainable.
Absolutely.
So that's when concentrating on keeping our patients healthy, preventive care, detecting diseases early with screening, and providers taking risk, right? Your family practice, internal medicine, we've been used to ordering stuff just because we can, right? Our licenses give us the license to order stuff without paying attention to the cost and what those tests tell us to help take care of the patient. Sometimes we just don't think about it. We do it because that's how we've been trained.
Yeah, sure.
And that has to change. So the other thing is patients will have to pay attention to their out-of-pocket cost. As things move forward, providers are going to be taking risk, but the patients will also have burden of taking care of their part of it. So again, preventive stuff will be cheaper than care of sick. And then making things patient-centric. We don't do anything patient-centric.
Yeah.
Even it's a good buzzword, but even our times,
Yeah.
office times, 8 to 5. Our patients go to work. If they don't go to work, they're not making money for their families, right? Patient-centric, Labs close at 5. So for them to go to do a diagnostic test or a lab test, they have to take time off. Pharmacies close. They're not, hardly any 24-hour pharmacies. So we don't even do that. Of course, we're making some efforts towards that, where we can mail in prescriptions and all that. But we need to do
There needs to be more
to make it patient-centric, to deliver care where they are.
Absolutely. This is, I can attest to this. I had a lipid panel that was sent to me that was over 7 months old, just more or less because I'd been working and hadn't had that drawn.
Yep.
Telling on myself in case my family doc's listening. But as we move toward this future of value-based and risk-sharing arrangements, what gives you the most optimism about where healthcare is headed?
I think, the only constant in the world is change.
Yeah.
Right? Cliche, but appropriate. I think we all want to do the right thing. And changing the environment where we can adapt and adopt new ways of doing things is, I think, what is of hope. What gives us hope is there are enough people in the healthcare industry that are really interested in making that paradigm shift to deliver health. I mean, I think we've had years and years of just status quo, and it hasn't gotten us anywhere very good. So I think what gives me hope is that a lot of new ideas, new technologies coming up. People are looking at delivering health in different ways, right? Remote patient monitoring, continuous glucose monitoring, there are a lot of these things. Fall prevention, right? Right now we have there's a bed alarm.
Yeah.
So when a patient gets up, that's when the bed alarm goes off and people start running to the patient's room. But now there's technology where cameras are available that AI agents look at the eye movements, body movements, and will actually speak to the patient saying, hey, are you trying to get up, Mrs. Smith?
Yeah.
And when Mrs. Smith says yes, says, hold on, let me get someone for you. And buzzes the nurse who comes and helps the patient get up.
Possibly mitigating like a hip fracture or I see, yeah.
Absolutely. So we're thinking outside the box. And what gives me hope is it's not just healthcare providers, it's technologists, it's people outside of healthcare that are bringing in their expertise into healthcare to make healthcare better.
That makes sense. Well, I'm a young whippersnapper. I am just at the beginning of my career. So what advice would you give to, frontline clinicians, whether it be primary care doctors, hospitalists, specialists, who could very well feel overwhelmed by this pace of change that's coming?
Embrace the change. Because if we don't, we're going to be left behind. The rest of the world is moving at a pace that we have not seen before, right? We used to have knowledge growth at a pace where new things were coming. A couple of years, today things are changing within 24 hours, and the world is moving much faster than we have ever had. And I think we should have an open mind and embrace the change, use the technology, use the ideas that are outside the box, right? One of the things you'll notice, most successful people have dropped out of college. Right?
Yeah.
And that's because we're trained with education to think in a particular way. Although we deny it, but there are algorithms set in our brains that we analyze things in those ways. We got to get away from that. And if we get away from that and think of it differently, we come up with new ideas, new ways of doing things that may be much better than what we were doing before. And for your colleagues, my colleagues, administration, people that are all involved in healthcare, for them to listen, and as people in technology would say, is it's okay to fail, right? Fail fast, change, and embrace that as a culture, personally as well as institutionally, and that's what will move us forward.
This has been Dr. Nanda, Chief Medical Officer of Vandalia Health Network, sharing insight into how population health and value-based models are transforming the way healthcare is delivered. As the industry shifts towards accountability, outcomes, and collaboration, it's clear that innovation isn't just about technology, it's relationships, shared goals, and a commitment to better health for our communities. Dr. Nanda, thank you for being with us today. We greatly appreciate your time and you sharing your expertise, as well as sharing the future of Vandalia Health.
Thank you. Appreciate you having me.
I'm Dr. Sheylan Spencer. This has been Health Matters. Thanks for listening.
Matters Today is a podcast recorded at Vandalia Health Charleston Area Medical Center Studios in Charleston, West Virginia. Hosted by Dr. Sheylan Spencer, directed by Dr. Amy Bruce, produced by Christopher Cobb and Jason Likens.